presenters from Dhanalakshmi Srinivasan Medical College, Head of the Department, Professor Tangaraj, and Dr. Priya is presenting from her clinic, namely the Sri Krishna Clinic in Trichy. So, chairperson for this meeting session is Professor Mukundan, Professor and Director of Institute of Neurology, Chennai. I will hand over to Professor Mukundan to conduct the proceedings. Professor Mukundan, sir, you can carry on.
Yes, sir. Good morning to all. Respected my teacher, Professor VN, sir, moderator, Professor Tangarai, sir, and the presenters and all the members. We will start the first case from Perambalur Dhanalakshmi Hospital case. I request Professor Tangaraj to proceed.
Jay Kumar, slide share la irukku.
Sir. Okay, sir. Sir. Is the slide is visible, sir?
Adha slide share la irukku. Neenga perusu pananum. Full screen போடுங்க. Full screen mode.
Okay, sir.
No, full screen mode வரல.
Slide.
Shafiq sir ஒரு help பண்ணுங்க share mode இன்னும் full screen வரல பாருங்க அது.
Sir, right corner you will be having the full screen mode, sir. Okay, sir. Okay, sir.
ஜெயக்குமார் அது போடுங்க full screen mode.
Yes, sir. Yes, sir.
Right hand corner சொல்றாரு.
Yes, sir.
இப்போ it's okay.
Is it okay, sir? Is it okay, sir? Okay, sir. Okay, sir.
Yes. Can proceed.
Okay, sir.
Mohan sir, proceed பண்ணலாம்ல அவரு.
Sir, பண்ணலாம் sir. Jaykumar.
Good morning to all.
Yes, sir. Yes, sir.
First of all, I thank Professor VN to give me an opportunity to present this interesting case. So it is going to be one of the interesting case, but we not at 100% diagnostic about this case. So I need your experience and guidance regarding this case. We will go start the case by Jaykumar.
Okay, sir. Myself, Dr. Raj Jaykumar. Hello, sir. Is it audible, sir? Hello, sir.
Sir, பாக்கி பேர்லாம் மியூட் பண்ணிடுங்க சார். ஷஃபீக், பாக்கி பேர்லாம் மியூட் பண்ணிடுங்க.
Yes, sir. Yes, sir. Yes, sir. I just muting all down, sir.
Okay, thank you.
Okay, sir. Is it audible, sir? Hello.
Yes, you are audible.
Yes, sir. You are clearly audible, sir. Okay, sir. Okay, so myself, Dr. Raj Jaykumar, Assistant Professor of Neurology from Dhanalakshmi Srinivasan Medical College. I'm presenting one of the interesting case of acute myeloid barrel syndrome. I thank Professor Tangaraj sir for giving this opportunity. Coming to the case, a 32-year-old male, a right-handed person, studied up to 10th standard, lorry driver by occupation, hailing from Manachalur, Trichy, presenting with chief complaints of difficulty in using both upper limbs for past 15 days. History of presenting illness, he was apparently normal 15 days back. After his work, he took a small habitual alcoholic drink and he went to sleep. When he woke up in the next day morning, he noted the weakness of both upper limbs in the form of unable to lift the arms and the difficulty in gripping the objects with the hands. He also noticed his right upper limb is more weaker than the left, and he noticed his both upper limbs are flail, hanging on his trunk. The weakness was maximum at the onset and was non-progressive, and also the weakness was static from the time of onset till now for the past 15 days. And no state of weakness referable to the lower limbs, neck or trunk, and no state of twitching or thinning of limbs, no state of diurnal variation or fatigability, no state of cramps or enlargement of muscles. And history of bending sensation in both arms and forearms since the onset of weakness, and there is no history of neck pain or shooting leg pain or shock-like sensation while bending the neck forwards, and no history of burning sensation, irritating pain, paresthesia or corneal sensation. And no history suggestive of any higher mental function involvement or the cranial nerve involvement. And no history of swaying or tremors or involuntary movements, no history of ball and bladder involvement, and no history of postural giddiness, palpitation or syncope, no history of fever, no history of preceding fever or the weight loss, no history of rashes or alopecia or non-healing ulcers. And coming to the positive, no history of diabetes, hypertension, bronchial asthma, TB, thyroid or heart disease, No history suggestive of trauma or history suggestive of whiplash injury. No history of recent vaccination or febrile illness or respiratory or GI illness. No history of drug, indigenous drug or the toxin intake. No history of similar type of weakness in the past. Coming to the personal history, he takes mixed diet. Sleep and appetite was normal. Normal all and blood habits. He's a chronic alcoholic, taking 160 to 320 ml of brandy per day for the past 6 years duration. Family history, he born out of non-consanguineous marriage, no history of similar illness in the family members. Coming to the summary, a 32-year-old male, a lorry driver by occupation, chronic alcoholic, presented with acute onset non-progressive neurological illness of 15 days duration in the form of asymmetric flail weakness of both upper limbs, right more than the left, the proximal more than distal, along with benign sensation of both upper limbs. And he has no lower limb, facial, neck or trunk muscle weakness, or the ptosis or dysphagia. He doesn't have any higher mental function, cranial nerve, cerebral or extrapyramidal or ball and bladder or other system involvement. Okay, coming to the discussion, according to the history, it is a case of element syndrome.
Jayakumar, 1 minute. Did he happen to have
Yes,
this
sir.
on waking up, or how did it develop?
Okay, sir. He went to sleep after taking a habitual alcoholic drink in the night, sir. After waking up, he noticed a maximum weakness at the onset.
Okay. Thank you.
Maximum the onset and the static from the day of illness till now, sir. For the past 15 days at the time of presentation to us.
Okay, continue. Please continue.
Yes, sir. Coming to the discussion, it is a case of acute element syndrome with sensory involvement involving bibrachial weakness. The possibilities are anteronsal, segmental, cervical segmental anteronsal or sensory with the sensory involvement. It could be a possibility of anterior spinal artery infarct, acute because of hyperacute to acute involvement. There is a possibility of vascular involvement. So we thought of anterior spinal artery infarct. The imaging classically shows the oval side, especially involving the anterior cell. And the second possibility is bilateral brachial plexus involvement. The etiological may be idiopathic or immune-mediated or infectious brachial plexitis. And one more entity is hereditary neuropathy with liability to pressure palsy. When the person sleeping in a hyperabducted person with hereditary prone to liable palsy can present with bilateral brachial plexus involvement. And third possibility is polyradicular neuropathy, the rare form of bibrachial GBS, that is pharyngo-cervico-brachial variant. But there is no progression beyond the 24 hours. So it's unlikely for a Guillain-Barré syndrome or AADP. And one more possibility is human syndrome with cerebral shock. Sometimes patient developed arrhythmias or cardiac arrest because of all-day hot or during a binge alcoholic drink. A patient may develop cerebral hypoperfusion, bilateral AC-NSA watershed infarct, secondary to the cerebral hypotension. Especially it is affecting the supplied by the arm areas in the motor homunculus. A patient may present with acute man in barrel syndrome after waking up from the bed. But there is no human signs. Sometimes in cerebral shock there may be a flaccid weakness only there, but still the examination will confirm the further evaluation. Okay, on examination, patient conscious, oriented, hydration is adequate, moderately built and nourished, and no pyeloerythritous or clubbing sinuses, lymphadenopathy, no neurocutaneous markers of peripheral thickening, and there is a PES curve is present on both lower limbs is present. Vitals temperature is normal, pulse is 82 per minute, regular, equally felt in all peripheral pulses, and the BP is 120/80, supine patient right upper limb, the respiratory rate is 16 per minute, abdominal thoracic, no paradoxical breathing. Higher mental function examination is normal. The examination of cranial nerve system also normal. Coming to the spinomotor system, the bulk wasting is noted in the supraspinatus and infraspinatus, deltoid and biceps and triceps, right more than the left. The tone was hypotonia in both upper limbs. Examination of the power, shoulder flexion, extension, abduction, adduction was 0 on the both sides, and the elbow flexion extension was 2 on the right side and 3 on the left side, and the wrist flexion extension was 4- on the right side and 4 on the left side. and hand grip was weak bilaterally. The weakness is more proximal than the distal. Examination of lower limb was normal. Coming to the reflexes, superficial reflexes was intact. Plantar was bilateral flexor, and deep tendon reflex, biceps, supinator, triceps are absent on both sides. And knee and ankle is 2+ on both sides. Coming to the sensory, bilateral C5 to T1 dermatom, there is hyposthesia, dimness sensation for touch and pain. Vibration, joint position was normal. Cortical sensation, autonomic nervous system, everything was normal. Other system examination, CVS, SNST heard, respiratory system normal, abdomen is soft. Coming to the case summary, a 32-year-old male, lorry driver by occupation, chronic alcoholic, presented with acute onset non-progressive neurological illness of 15 days duration in the form of asymmetric flail weakness of both upper limbs, right more than left, proximal more than distal, along with the minimal sensation of both upper limbs. He has no lower limbs, facial, neck, muscle weakness, or ptosis or dysphagia. He doesn't have any higher mental function, pain, no cerebral or extrapyramidal, bowel and bladder or other system involvement. On examination, he has a chest cavus deformity, asymmetric areflexic flail weakness of both upper limbs, right more than left, proximal more than distal, with hyposthesia C5 to T1 dermatose bilaterally, with no other system involvement. Coming to the discussion, same thing.
He did not have pain at the onset, no pain at all.
No, sir. I said no pain at all, sir.
Okay.
Okay, coming to the discussion, the human with cerebral shock after 15 days there is no human signs. So possibly we rule out a bilateral ACMC cortical watershed infarct. So the other possibilities, I think the first possibility is bilateral brachial plexus, and then polyradicular neuropathy, and the anterior cell with sensory involvement, acute anterior cell with sensory involvement also the one of the possibility. Another possibility.
No, to think of ACAC by ACMC bypass, I'm sorry,
Yes,
bilateral watershed infarct.
Watershed infarct, yes, sir.
Was there
Yes, sir.
any cardiac ailment? Was there anything to suggest that it was?
No, sir. No, sir. Only thing is a patient is alcoholic. After binge intake of alcohol, there may be arrhythmias, all-day heart syndrome, like that. After that, a patient developed cerebral hypoperfusion can develop ACMC watershed infarct.
Correct, but anything to suspect a cerebral hypoperfusion? Was his BP dropping, or was he in a stage of shock? Was he in a state of altered sensorium at all? Did he have palpitations?
No,
anything to suggest?
No, sir. Actually, no history suggestive.
Okay.
Suggestive, sir.
Right. Okay, you continue.
Okay. Coming to the investigation, routine investigation, CBC, everything is normal, and the ESR is 26 millimeter of mercury. And the CPK was 900 intention units, and day 15 of illness, and thyroid profile was normal, and vasculating ANA profile was negative. Coming to imaging, we did a MRI also. MRI is MRI brain normal, and the MRI C spine and whole spine steady. It is also normal. And we did a MRI bilateral brachial plexus. The patient did the MRI bilateral brachial plexus on day 3, the outside MRI. It shows myoedema in the right scalene muscles with enlargement and edema of the both brachial plexus. This was noted, sir. Actually, right side scalene muscle, there is some hyperintensity is there. It is a myoedema of the right scalene muscles. Scalenus muscles. After the day of 15th day presentation, at the time of presenting to us, we did the MRI brachial plexus with contrast study. It was normal. The edema of the muscles and the brachial plexus, everything was came down, and it was normal.
Is he a diabetic?
No,
Not
sir.
diabetic.
No, sir.
He's not a diabetic.
Not
Yes,
yet
sir. It's a non-diabetic, sir.
Okay.
Okay, we did the first NCS bilateral brachial plexus. It was normal at the time of admission. We repeated the nerve conduction after 10 days. It shows CMAP amplitude was reduced in both median, ulnar, radial, the axillary and suprascapular nerves with absent X-rays. At the time of presentation, the NCS was normal, sir. At the time of 15th day, at the time of presenting to us, it was taken at the 28/4/25. The CMAP amplitude of median, both right and left, it was normal. When compared to after 10 days, it was CMAP amplitude was reduced with maintaining nerve conduction velocity and latency. And FA was present on the 28/4, but the FA was absent on the 8/5/25, sir, on the median now. The ulnar amplitude also slightly reduced when compared to the previous nerve conduction study, and the FAs are will be present on both. The radial lobe conduction also there is a significant drop in amplitude in compared to the first NCS and after 10 days of the NCS study. The axillary also amplitude drop is there. Musculocutaneous also the amplitude drop, and the right suprascapular also there is amplitude drop when compared to the within the 10 days interval of the nerve conduction study. And we did a CSF study. The CSF analysis shows ASLR, normal protein and sugar, and no organisms was growth in culture. Lactoferrin MOG and OCT was negative in the CSF study. Okay, coming to the discussion, is after the investigations, we are localizing the lesion to bilateral brachial plexus. It could be three possibilities. One is intraocular neuropathy due to rhabdomyolysis, alcohol-induced rhabdomyolysis in vivo for myoedema and the MRI, and slightly elevated CPK. And the second possibility is hereditary neuropathy with liable to pressure palsy with acute compressive plexopathy. And these possibilities think in view of the Pescav's deformity was present in the patient on examination findings. And third possibility is it may be idiopathic or immune mediated or infectious brachial plexitis. Coming to the we searched for the similar cases in the update, and there was a interruptment brachial plexopathy secondary to the alcohol-induced rhabdomyolysis. The similar cases was reported, one in the 2011, one in the 2018. The acute rhabdomyolysis and the brachial plexopathy following alcohol ingestion. An unusual case report of brachial plexopathy following a alcohol-induced rhabdomyolysis. The patient rhabdomyolysis developed during the sleep after acute alcohol binge, and there was no history of muscle trauma, and it was thought to be brachial plexopathy secondary to the direct compression of the plexus from the Solomon muscles of the shoulder girdle. And the similar case, another case was reported, a case of complete bilateral brachial plexus injury from the rhabdomyolysis and compartment syndrome. A 32-year-old male presented with acute complete bilateral brachial plexus palsy due to focal rhabdomyolysis and brachial plexus compression after a night of excessive alcohol methadone ingestion. He has a complete loss of motor and sensory function from the C5 to T1. And the second possibility is HNPP with acute compressive brachial plexopathy, hereditary neuropathy with liable palsy presenting as an acute brachial plexopathy. It was we described a young man who developed a painless flail upper limb weakness with a clinical diagnosis of brachial plexopathy after his partner slept on his arm. The another case report was a characteristic hereditary neuropathy with liable to pressure palsy presenting as a brachial plexopathy in the soldiers. Actually, 189 young Korean soldiers diagnosed with the brachial plexus lesions. The hereditary neuropathy with liable palsy was diagnosed in 6.5%. And the push-ups was the most frequent exclusive preceding event in the all HNPP patients for the excessive workload. These soldiers in the Korean soldiers. And the another case was hereditary neuropathy with liable palsy presenting as bilateral brachial plexopathy. A 20-year-old male with no relevant personal or family history was transferred to presenting with proximal weakness of left arm, persisting for 3 weeks. On examination, he has bilateral brachial plexus involvement, and the similar case report was reported. The one of the gene involved is a peripheral myelin protein 22 gene, PMP22 gene was the culprit in the HNPP genes. Okay, that's all, sir. In our case, it is an intraocular neuropathy. Either it is intraocular neuropathy due to rhabdomyolysis, or it could be a HNPP with acute compressive myelopathy. With further genetic studies, we would like to proceed the case.
Was the CPK repeated?
9:30 something.
That was the first CPK. Was it repeated later?
Like we did it late, sir.
We did it after 15 days.
15 days.
Okay, but subsequently, did you repeat it to see what is value? அதுக்கப்புறம் பண்ணல.
No, sir. Patient discharged.
Okay. And the treatment you gave?
treatment
Sir,
as
steroids
usual.
over 5 days.
Steroid, steroid, but no improvement in after steroid. Methylprednisolone
Steroids.
we gave, and followed by oral prednisolone. But not he not turned up for a review till now.
Okay, sir. Okay. It looks like what you have highlighted due to
So
rhabdomyolysis and
we
myoedema, and
never thought of
you also have
we
literature support for it.
actually
Sir,
what we
HNPP also one of the possibilities. If escape is there, and similar case reports for HNPP with acute compressive myelopathy also the literatures are showing similar cases only. Sir. The genetic study confirm the
No,
diagnosis. Sir.
bilateral acute compressive myelopathy, I mean, plexopathy happening suddenly. Between the two, I think the first
As a
possibility
patient,
is higher.
as a patient sleeping in the hyperabducted position after the alcohol binge, sir. After
Yes,
alcohol
yes.
binge, it would happen, sir.
Correct.
Hyperabducted position. After hyperabducted, sleeping in a hyperabducted position in the alcoholic binge, it can happen, sir.
Yeah, that HNPP doesn't explain the MRI finding and the CPK, isn't it?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
So, opinion from others.
Sir, both conditions can coexist. Patient with HNPP is more susceptible for pressure palsy. So probably the muscle edema has more easily caused a bilateral brachial plexopathy. Sir. So both in a HNPP patient who has taken alcohol.
Why do you want both when one itself is sufficient? Chitramalam sir, why do you want both?
Yes, sir, because it is bilateral and subtle muscle edema could have caused a compression because the nerves are susceptible, sir. So probably this patient, even though alcohol is the trigger, probably the basic cause of HNPP to be ruled out by a whole exome sequencing.
Sir, the initial nerve conduction study of brachial plexus was normal.
Normal, yes, sir. Normal, sir.
So that will not be favoring HNPP. You may have some findings in lower limb and upper limb also initially. So, and again, alcohol-related myoedema producing complete, phlegm, which is not reversing even after 15 days. I think we have to rule out CSF is not done, right, sir?
Yes, CSF done, sir. CSF was normal, sir. We did CSF, sir.
Okay. So,
ASL, normal protein and sugar, sir.
Form of some viral inflammatory or some form of immune mediated also is one possibility. But it's actually considering the MRI findings, I agree there are some muscle edema, but we couldn't able to rule out an inflammatory condition also.
Inflammatory condition, yes, sir.
The HNPP, does it have a normal conduction effects in even when it's not symptomatic? Do you have a HNPP? Should it have features of CMT otherwise in nerve conduction? Only their susceptibility to pressure palsy. That's all. Liability is there.
Palsy, yes, sir. Yes, sir. HNPP patient can have normal nerve conduction, sir. Normal nerve conduction can have
this is patient with HNPP who has a pescavus. Why should someone have a pescavus? And patient with HNPP is more liable for a nerve compression. More subtle muscle edema could have caused that.
Yes, sir.
So I think HNPP should be ruled out in this patient.
But other conduction study, totally lower limb, everything is normal. No nerve thickening or focal nerve thickening.
So
This is
MRI
the first
doesn't show any evidence of brachial plexus contrast enhancement or thickening. So that's what the concern is. In HNPP, you have some findings of focal nodular swelling of the brachial plexus, just like in neurofibroma. Like
Interesting, very interesting. Yes, sir.
Goodman is there.
Sir, this
It's a genetic study will confirm, sir. Actually, we are not familiar with there is no more number of cases of HNPP, sir. So genetic study probably will detect to rule out HNPP, sir.
Hello, sir.
Hello, sir.
Yeah, correct.
Dr. Thirur.
Anyone has seen HNPP
Go ahead, sir. Thirur, go ahead.
Why not? It's bibrachial variant of GBS.
Yes,
Sorry,
sir.
why not?
Bibrachial variant of GBS.
GBS. But
Yes, sir.
it's a
We also
hyperacute onset
think
and
like that, sir.
non-progressive.
Hyperacute onset, non-progressing, sir. On the day 15, the protein was normal, sir. There is no cytoalbuminergic dissociation, sir. The day 15 of illness, there is no protein elevation, and there is no progression after 24 hours, sir. This is against GBS, sir.
The one by initially normal health condition had from
Jayakumar,
Yes, sir.
what is the distribution of the myoedema and what are the conditions in which muscle edema happens? What is the distribution in this patient?
So right side is
Actually,
more
this page,
myedema.
Sorry?
They described the first MRI. The patient came with the first MRI.
Yes.
Right scalenus muscle, there is a myoedema.
No, was it confined only to the scalenus muscle?
Yes.
No other.
yes, sir.
No,
Yes, sir.
More on the right side.
none of the scapular muscles, none of the pectoralis, they were all.
No other muscle edema noted.
Oh, okay.
When the patient comes with this clinical symptom, we thought of first idiopathic brachial plexopathy.
It was one-sided, isn't it? Right-sided.
Usually idiopathic brachial plexopathy, usually unilateral, start with the pain.
Yeah, that's okay. In this patient, I'm asking.
Then followed by motor weakness. But here, no pain at all. Just he took alcohol, went to sleep, and the next day morning he developed a bibrachial weakness.
That's Parsonage-Turner syndrome. That's okay. Or brachial amyotrophy, neuralgic amyotrophy.
15% of the brachial idiopathic brachial plexopathy can present as bilaterally without even pain. Also, they know.
Correct.
Here also there is predominant involvement of upper brachial plexus compared to lower. The weakness predominantly confined to C5, C6.
No, we are postulating myoedema as the cause. But it is bilateral. We show the edema only on one muscle on the right side. So that could not have caused it on the left side also.
They gave.
Sir, was HIV done?
Yes, sir. HIV done, sir. Negative, sir.
Blood sugar, urea, creatinine, electrolyte, everything is normal, sir.
What was the radiologist report?
Radiologist report was skeletal muscle hyperintensity on both sides, right more than the left, sir.
Oh, both sides.
Sir. Sir. Both sides, right more than left, sir.
So
second MRI normal.
So what are the
normal, sir.
Okay. Now, what are the conditions where you get focal muscle edema, skeletal muscle edema? What are the conditions on review? Literature review. Does it show any particular?
Yes, sir. Alcohol itself. Alcohol itself can cause a focal rhabdomyolysis. Sir. Alcohol itself can cause focal rhabdomyolysis.
He's a driver. He drove he's driving heavy vehicle, whether with a local muscle stress.
Okay. Thank you. Mukundan, sir.
Sir, it's a very rare case. We have seen HNP in lower limb only, but in upper limb I have not seen the possible myedema with the rhabdomyolysis. It's a thing. So it's a rare case only. Follow. Thank you, sir.
Okay.
Sir?
Yeah, you can go to the Dr. Priya's case. Thank you, Jayakumar, and thank you, Thangaraj, for bringing in a very interesting case. As pointed out, one of those rare cases. I have also not come across such a presentation, and many probably have not come across. So it's thank you for highlighting this patient, this case, and alcohol-related rhabdomyolysis causing bibrachial palsy. Thank you, sir.
So when you drink barrels of
Thank you,
alcohol,
sir.
you can develop a man in barrel. That is the end of it, sir.
Thank you, Mr. Malam.
இந்த கேஸ் யாரும் பார்த்ததில்ல.
Yeah, we can go to Dr. Priya's case.
Sir, can I?
Yes, please.
Good
Chairperson,
morning.
can Dr. Priya start? Mukundan sir, can Priya start?
Dr. Priya, you can start.
Thank you, sir. Good morning. I would like to thank Professor Vigan sir for giving me this opportunity and thank Professor Mugundan sir for chairing the session. I'll share my presentation. Is my slide visible?
Yes, ma'am.
So I'll be presenting some of the interesting cases in neuro-ophthalmology. This is the first case. She is a 53-year-old female presented with decreased vision both eyes for the past 3 months. History of pain, redness, watering of both eyes with mild visual disturbance in Jan 2025. She consulted an ophthalmologist. She was given IV methylprednisolone 500 mg per day for 3 days. All her symptoms improved and she was followed with topical steroids. After that, she was asymptomatic for a month. In March 2025, she developed progressive visual blurring both eyes. This time it was painless. There was no pain on extraocular movements. She's a school administrative staff and she was unable to read the WhatsApp messages. She had no difficulty in appreciating colors. During the second episode, she consulted the ophthalmologist again, who referred her to a neurosurgeon because the ophthalmologist had noted bilateral disc edema. The neurosurgeon took an MRI and he found nothing significant and he referred to a neurologist. The neurologist had started her on tablet Diamox 250 mg half TDS, but she had no improvement in vision. She did not have any history of headache, vomiting, double vision, transient visual obscurations, tinnitus. There was no complaints of redness, watering, photopsias, floaters, worsening of vision in the night during this episode. There was no history of weakness, unsteadiness, or numbness. She has a significant past history of concurrent CA ovary and CA lung with METs diagnosed in 2021, and she underwent total abdominal hysterectomy and bilateral salpingo oophorectomy. After that, she completed 4 cycles of paclitaxel and carboplatin. Palliative neck radiotherapy also was given. Both her intensive chemo and radio was completed 2 years ago, and she is presently on nivolumab monthly cycles, 31 cycles completed. There's no history of diabetes or hypertension, no history of joint pain, rash, fever, or vaccination preceding the illness. Coming to the examination, her BP is 130/80. She is conscious, oriented, high mental functions are normal. Pupils are equal, reacting, there is no RAPD. Vision is 6/12 in both eyes. Her color vision is normal. It was tested by Ishihara's plates. It was normal. Fundus showed bilateral disc edema, no hemorrhages or exudate. Extraocular movements were normal. Rest of the cranials were normal. Motor, sensory, cerebellar examination were normal. This is the visual field. This is the field on the left side. This shows a superotemporal patchy peripheral defect and a little bit of defects on the superonasal quadrant also. Again, on the right side, in the superonasal quadrant, more in the periphery, there were patchy defects. Summarizing, this 53-year-old lady had presented with pain, redness, watering, and mild visual blurring in Jan 2025. Redness, watering, pain, and visual blurring improved with IV methylprednisolone, and she was followed with topical steroids. In March 2025, she developed progressive painless visual blurring. She was detected to have disc edema at that time. She had presented to us in May 2025. On examination, she had bilateral disc edema with decreased vision of 6 by 12, normal color vision, patchy field effects in the periphery, with a past history of CA ovary, lung with metastasis on immunotherapy, and with past history of chemo and radiotherapy. This is the timeline. It all started in 2021 with CA ovary and lung, total abdominal hysterectomy, oophorectomy done. And then she was put on chemotherapy, paclitaxel and carboplatin with the palliative neck RT. This was completed by 2023. She was started on nivolumab after that. And in 2025 Jan, she developed redness, watering, pain, and mild visual blurring. She was started on IV methylprednisolone, followed by topical steroids. Her symptoms improved. In March 2025, she again developed progressive visual blurring, and she had presented to us in May 2025. So, first trying to differentiate whether this disc edema is a papilledema or optic neuritis. She had red flags for both. For papilledema, there were no symptoms of ICT. Her visual blurring was disproportionate to edema, and she was not very responsive to acetazolamide, though the dose was not appropriate. And for papillitis, there were again red flags.
Priya, sorry for intruding.
Yes,
See,
sir.
what was the visual acuity at that time?
First
That is
time or
important.
second time, sir? 6 by 12.
The first time itself. Second time you said
First-
6 by 12.
The first time she had consulted an ophthalmologist, no records were available except for the bills, pharmacy bills which showed IV methylprednisolone and topical steroids. We don't have any idea about what was the visual acuity on the first episode. It was in a different ophthalmic hospital, couldn't get the records from that hospital, sir. Second episode, it was 6 by 12.
No, you are trying to differentiate papillitis from papilledema. Unless we know the visual acuity, it would be very difficult. I mean,
Yes, sir.
visual acuity is the key point.
6 by 12, sir.
Correct. That's the second one. First one
First
is,
time,
if you started, is it a papillitis or a papilledema? Then discussion ஆரம்பிச்சிங்க.
Ama, sir.
Unless we have a visual acuity, it would become very difficult to say papillitis because papilledema was noted. Could it just be papilledema?
Sir, the first episode was in Jan. That was predominantly redness, watering of eyes, and very minimal visual disturbance. And that
Correct.
improved with IV methylprednisolone followed by topical steroids. And after that, this is the second episode. This started in March, and now the visual acuity is 6 by 12, both eyes, sir.
That is understood. Yes, ma'am. Go ahead. You are trying to differentiate papilledema and papillitis. Go ahead.
Yes,
with
sir.
that.
Yes.
First time it is painful.
First time it was painful, but we are not sure about whether she had disc edema on the first episode. What was observed was redness, watering, and mild visual disturbance. The patient wasn't much worried about the vision during the first episode. It was the redness, pain, and watering that took her to the ophthalmologist during the first episode.
Are you continuing?
Yes, sir. The red flags for papillitis are painless visual blurring, color vision being normal, and the visual field did not show any central scotoma. There were patchy peripheral field constrictions. So with this, thinking of what could be the conditions that could involve the optic nerve associated with malignancy, leptomeningeal metastasis can cause infiltrative optic neuropathies, but they happen with different kinds of malignancies like leukemias or lymphomas. Sometimes toxic optic neuropathies can present with the decreased vision, especially with platins and taxanes. Our patient had received both, but the timeline was very different. There is no clear temporal association. And also thinking about the paraneoplastic optic neuropathy, the tumor seems to be in remission. So it looks a little less likely, but usually the paraneoplastic optic neuropathy may be associated with involvement with other neurological domains like cerebellar ataxia, peripheral neuropathy, etc., though they can occur in isolation as well. One interesting literature evidence was NMO spectrum disorders can be associated with malignancy. Several case reports of paraneoplastic NMO spectrum disorders with anti-aquaporin antibody positives have been reported. And lastly, the radiation optic neuropathy. This is unlikely because the patient did not receive any cranial radiation.
Priya,
Yes,
again,
sir.
sorry for intruding. See, nivolumab is a checkpoint inhibitor, am I right?
Yes, sir.
And show me your timeline again of the problem. The symptoms started after nivolumab, am I right?
Yes, sir.
So it is very likely a checkpoint inhibitor induced symptoms, both PAPs as well as the whatever other visual symptoms. Because checkpoint inhibitors can cause optic nerve in normal, I mean, including papilledema.
Okay.
You go ahead.
So the blood investigation showed normal counts, ESR, CRP, blood sugar was normal, renal function, liver function, thyroid function tests were normal, B12 levels were normal, AC levels were normal. This is the OCT of ONH, which showed bilateral disc edema. The OCT of macula showed edema of both macula. The arrows point to the macular edema. And VEP done showed increased P100 latency on the right side, 114, and left side was 116. Amplitudes were slightly low. On the left it was 4 and right was 3. MRI brain with contrast was normal except for the small Fox meningioma on the left side. And PET-CT was done in Jan 2021. Did not show anything much significant. There was a suspicious lesion in the right parietal lobe as pointed by the arrow, but that was not seen on the MRI, so it was considered as insignificant. CSF was done mainly to rule out any infiltrative or infectious cause. So CSF showed no cells, protein and sugar were normal. CSF opening pressure was normal. AFB gram stain was negative. Culture showed no growth. Cytology was negative for malignant cells. So ANA was weakly positive. NMO and MOG antibody were negative. So she was treated with IV methylprednisolone 1 gram OD for 3 days. It was followed by oral steroids. She made very good recovery in vision and resolution of disc edema and macular edema was present. Patient was suggested to avoid ICIs.
What is ICI?
Sir, you have already told, sir.
Oh, it's immune checkpoint inhibitors.
You have already broke the suspense, sir.
No, I just want to know ICI. Yes. Okay. Thank you. Go ahead.
So post-treatment OCT ONH showed resolution of edema and macular edema was completely gone. So ICIs are nothing but immune checkpoint inhibitors. Nivolumab is one among them, and this is a case of nivolumab-induced optic neuritis, as said by Professor Vian. What are ICIs? Why do they cause optic neuritis? Neuro-ophthalmological complications of ICIs and ICI-induced optic neuritis. I'll be going through these headings. So what are ICIs? Basically, what are immune checkpoints? Whenever an antigen presenting cell presents the antigen to the T cell, it does it through the MHC complex as shown by the red arrow. But there are something called immune checkpoints which protect the self antigens from the immune response. So there are 3 immune checkpoints, PD1, PDL1 and CTLA4. Basically, these immune checkpoints, when they are present, the T cell doesn't get activated. And so an immune response is not mounted against that antigen. So these are the 3 immune checkpoints. The tumor cell, because it is basically derived from the native cell, it makes use of this immune checkpoint to pose as if it is a native cell and thereby escapes from the immune system. So by developing these immune checkpoint inhibitors, what we have done is we have abolished this mechanism of escapism of tumor cell so that the T cell can get activated and can kill the tumor cell. The original cytotoxic chemotherapy acts on the various stages of cell cycle. So they produce a lot of toxic side effects that happen with rapidly proliferative cells. But these immune checkpoint inhibitors follow a different mechanism of action. So they have a different profile of side effects. So immune checkpoint inhibitors enhance adaptive immune response. Now widely used to treat many forms of cancer. They are basically monoclonal antibodies that block and inhibit immune checkpoints. They are of three types: cytotoxic T lymphocyte associated antigen 4, programmed cell death protein 1, and programmed cell death ligand 1. Nivolumab comes under the PD-1 immune checkpoint inhibitor. Because they potentiate the T cell response, the T cells can sometimes become unrestrained and they can target the normal tissue and they can produce a wide variety of adverse inflammatory events. And such events can also happen in the ophthalmic and neurological system. The incidence of neurologic immune-related adverse effects is 1 to 5% for monotherapy and 12% for combination therapy. So various adverse effects can happen starting from keratitis, uveitis. Probably our patient had uveitis on the first episode and later on went to develop optic neuritis. So even myasthenia, inflammatory orbitopathy, giant cell arteritis can occur. So the ones important for us as neurologists are optic neuritis, orbital inflammatory syndrome, thyroid eye disease, giant cell arteritis, and myasthenia gravis. So still the questions of why the patient presented as painless visual blurring and why the color vision was still retained and why the visual defects were very patchy was still to be answered. So going into the literature, the immune checkpoint inhibitor associated optic neuritis was published in Ophthalmology Journal. This was by Francis et al. According to this article, the ICA-associated optic neuritis had features that are not consistent with the classical triad of unilateral decreased vision, dyschromatopsia, and pain. The unique features of bilateral painless decline of vision in the context of intact color vision is very unlike the classical optic neuritis. In this paper, the author showed that out of the 18 cases of optic neuritis, 90% had painless decreased vision, 64% were bilateral, and 67% alone had dyschromatopsia. And again, coming to the visual fields, normally we expect the papillomacular bundle to be much affected in a patient with toxic optic neuritis. But here the visual field patterns are very variable. They can be diffuse, they can be arcuate, altitudinal, central, centrocecal, or sometimes there can be no defect also. That explains the patchy defects in our patient. And again, painless visual blurring was characteristic of this type of optic neuritis, though there is no clear explanation to why it was painless. And most of the patients had mild to moderate disc edema as in our patient. So conclusions of this paper were ICA-associated inflammation on the ocular structures are extensive, can be profound, including optic neuritis. It tends to be bilateral with painless visual decline, more often with intact color vision. Typically occurs within 4 cycles of ICA therapy, but they have the potential for late occurrence as in a patient because of, especially in the case of monotherapy, the occurrence can be late. Visual fields and MRI can be useful diagnostic tools. Visual field patterns can be variable, not necessarily restricted to central defects. Systemic steroids have the potential to retain or improve the vision. In refractory cases, IVIG plus rituximab can be used.
Priya,
Yes, sir.
could not all the visual deficits, defective vision, be
Yes, sir.
due to papilledema itself? Why are you bringing in optic neuritis again and again without significant visual, acuity defect?
So the CS of opening pressure was very much normal, sir. It was 16 centimeters. The opening pressure was normal. She did not have any symptoms of raised ICT. And nivolumab-induced optic neuritis is known to present this way. The visual acuity need not necessarily be very less in nivolumab-induced optic neuritis. It can be very subtle, and it has to be identified at that stage.
But what about the PAPs then?
It was not papilledema, sir. It was disc edema due to nivolumab-induced optic neuritis.
Like MOG disc edema.
Yes, sir.
But you are still saying it is optic neuritis.
Yes, sir.
Yes, this is again
normal
this is a
color
case
vision.
which this again teaches that we can't give just like that give Diamax and steroids for all patients. That is again another lesson to ophthalmologists and some neurologists also. Any optic nerve swelling give steroids and give Diamax. That should be also be another lesson from this case, sir.
What was the ophthalmologist's opinion, Priya?
Sir, ophthalmologist was really perplexed with the disc edema. They had referred to me saying that the patient is progressively losing vision, but the disc edema is not that severe for her to lose this much vision. But her color vision is normal and the fields are also erratic. So we don't know really what this is. That's why they referred to me, sir.
Progressive visual loss என்றாங்க ஆனா visual acuity வந்து reasonably good.
விஷுவல் அக்விட்டி அவங்கள பொறுத்த வரைக்கும் அவங்களோட டே டு டே ஆக்டிவிட்டிஸ் அவங்களால பண்ண முடியல சார். ஷீ இஸ் அ ஸ்டாஃப் ஒர்க்கிங் இன் அ ஸ்கூல் அண்ட் ஷீ இஸ் நாட் ஏபிள் டு டூ ஹர் ரொட்டீன் ஆக்டிவிட்டிஸ்.
That's okay. Blurring of vision, there was watering of the eyes, redness of
So
the
that
eyes.
watering, blurring all was only in Jan, sir. That improved with steroids. After that, she never had any watering or redness. The second episode started in March. That was when the disc edema was detected.
So, what is the first time she responded to steroids?
The first time, we don't know what the ophthalmologist initially diagnosed her, but looks like it was
But they gave
a case
steroid,
of
patient
uveitis.
improved.
It
But
was a
they
case
gave
of
steroid, patient improved.
probably they thought of uveitis, sir. I'm not sure, sir. I couldn't get the
Any
record.
ophthalmologist coming across any disc edema, they give steroids. There's no, they don't even make a big diagnosis. They start IVIG, they start methylprednisolone 1 gram, 3 to 5 days they give, then only they send to anybody. So not that they make a specific diagnosis and give steroids. They just give steroids for all. Yes, sir.
சிற்றம்பலம் அது மாதிரி
Yes,
ஒரு
sir.
blanket statement சொல்ல முடியாது. No. Not many ophthalmologists when they find a disc edema immediately start steroids. Some
Yes,
may
sir,
do
they-
it, but not.
Yes, sir, they do an MRI and they rule out a tumor. That's all, sir. They rule out a big SOL, then they give steroids. 99% of the ophthalmologists.
I don't know. They pass it on to the neurologist as it has been done. They pass it on to the neurologist. Unless
But
they feel it is an optic neuritis, I have not seen the ophthalmologist starting them on steroids. Maybe it differs. I don't know.
Sir, nowadays more and more cases of IIH diagnosed with the MRI without doing their simply reporting it is idiopathic intracrinial.
சரி பரவாயில்ல ஐஏஹெச்க்கு ஸ்டீராய்டு போடுறது இல்லையே. They don't start them on
I am not
steroids.
telling this case. I am not telling this case.
This case was probably given steroids for uveitis, sir, because she was on topical steroids for a month. Nobody gives topical steroids for a case of disc edema.
Yes.
And patient had severe pain, redness, and watering. These three things don't happen in normally in the case of papillitis: redness and watering. Pain, okay, but redness and watering. So probably the first episode was a nivolumab-induced uveitis.
Correct. Maybe yes.
Papillitis also produce painful vision loss.
But redness and
Watering.
watering was there, sir. Severe redness. She complained of severe redness, sir. When I specifically asked whether there was any visual disturbance, she said yes, the vision was slightly disturbed. But her main history was that it started with redness and watering. That's what she herself came out and said. So maybe that was a case of either orbital inflammation or uveitis because she was put on topical steroids.
Good, Priya. Thank you. You were about to start the second case.
Yes,
If
sir.
with Mukundan, okay for her to
Sir.
start the second case? Unless there are more comments on this.
We'll go to the second case.
The second case is a 65-year-old male with bilateral drooping of eyelids for the past 3 days, right more than left. History of double vision present, horizontal double vision, more for distant objects. He was not sure about the direction of diplopia. History of fatigability and diurnal variation were present. There was no difficulty in chewing, swallowing, articulating, no limb weakness. History of acral malignant melanoma, stage 2B in left thumb, diagnosed in Jan 2024. He also had coexisting TB adenitis. He was on ATT. On nivolumab, 200 milligram per day every 2 weeks, completed 3 cycles so far. On examination, he has bilateral asymmetrical ptosis, right more than left. Fatigability was present. Extraocular movement showed bilateral adduction and left abduction weakness. Pupils were equal reacting. Vision was normal. Single breath count was 32. Arm rise test showed no fatigability. No other focal neurological deficit. So this is the patient showing bilateral asymmetrical ptosis, right more than left. On gaze to right, there was mild adduction restriction on the left eye. On gaze to left, there was adduction restriction on the right eye and abduction restriction on the left eye. So it's a 65-year-old man presented with bilateral ptosis, double vision, fatigability, diurnal variation. Patient is on ICI nivolumab. So we already know the diagnosis from the past experience. Acetylcholine receptor antibody was high, 3.69. The history was very short, it was only 3 days. He already had come with PET, which was suggestive of few skeletal metastases. This is a biopsy report showing caseating granulomatous lymphadenitis, the reason why he was on ATT. The creatinine kinase level was high, 803. RNS showed mild decremental response in right orbicularis oculi and both orbicularis oris. No decremental response in limb muscle seen. Investigation showed normal blood investigations. CBC, blood sugar, RFT, LFT, thyroid functions were normal. MRI brain, he had already come with an MRI to me, that was normal. CPK was 803. ECG was normal, echo was normal. So the diagnosis is already clear. It's a case of nivolumab-induced myasthenia gravis, MGFA class 1. I'm presenting this case mainly for the therapeutic challenge. How to treat ICA-induced myasthenia? Is the management different from a classical case of ocular myasthenia? I would like to know from the audience if anybody had a similar experience and had managed a case of nivolumab-induced myasthenia. So this was the first case of nivolumab induced problem that I encountered. This patient I saw in 2024. At that time, I was not much aware about these ICA checkpoint inhibitor induced adverse reaction. So when I diagnosed myasthenia, I called up the oncologist saying that's the case of myasthenia, sir. So I would like to do the investigation, start the patient on pyrostigmine and probably a low dose of steroid. The minute I said it is myasthenia, he was alarmed. He was aware of the myasthenia gravis problem with nivolumab, and he said that don't think that it's a normal classical case of myasthenia. It behaves very differently. Please read the literature. You might have to treat the patient differently. So I went into the literature. Myasthenia gravis induced by immune checkpoint inhibitors. This was from Marco et al. And according to this article, myasthenia gravis induced by immune checkpoint inhibitor can occur as an exacerbation of pre-existing myasthenia, or it can occur de novo as in a patient. It is characterized by progressive weakness affecting extraocular, bulbar and limb muscles, progressing to respiratory failure in a whopping 40 to 65% of the cases. That doesn't happen with the classical myasthenia. Some patients have mild symptoms like ptosis, while others can present with rapidly progressive respiratory failure with fatal outcome. The presence of myositis and myocarditis overlapping with myasthenia is a very common association. It is known as 3M triad. It is especially challenging and life-threatening. So this paper is a series of 6 cases from the same center. In this, there was one patient who had this combination of melanoma and nivolumab as our patient. And there was only one patient who presented with only ocular myasthenia. Now the challenge was whether to treat him only with steroids or to give him immunoglobulin. This patient with ocular myasthenia was treated with only steroids. The rest of the patients required a combination of steroids and other treatment like IV immunoglobulin or Plex. The problem was death was reported in 4 out of the 6 patients. That was really terrifying. So according to this paper, the immune-related myasthenia gravis is much different from classical myasthenia gravis. Isolated ocular presentation is less common. Usually they progress. Association with thymoma is not there. They can be associated with myositis or myocarditis. In our patient, the CPK levels were high. Anti-acetylcholine receptor antibodies may be positive. MuSK is usually negative. RNS may or may not be positive. And mortality is very high. Classical myasthenia with the modern treatment, we don't have much of mortality. But in this group of patients, mortality is very high. This paper suggested that a very recent study showed that patients with IRMG may benefit from initial therapy with IVIG or PLEX, regardless of the initial severity, which was applied in the most recently diagnosed patient series of ours. And again went into another paper by Marini et al. This is from our own neurology journal. This is a case series collected from multiple centers. So there were 58 myasthenic patients in this. They had used only steroids in 33%, and in 45% they had combined steroids with other immunomodulatory treatment. And again here, death was reported in 28%. So this is the opinion-based management algorithm by Zubair et al. In this, they had suggested that in MGFA class 1 ocular myasthenia, steroids alone can be used. Again, they had given a classification called severe ocular myasthenia. They did not quantify what is severe ocular myasthenia, and they had suggested that both steroids and IVIG should be used here. So I really didn't know how to manage this patient. I basically wanted to try IV methylprednisolone and probably see what is happening and then add on immunoglobulin. We sat with the relatives. We explained them this is iatrogenic effect of nivolumab and the course can be stormy. We said that we'll keep the patient in the hospital, start him on IV methylpred and see if it's worsening. We also explained them that sometimes steroids can worsen the clinical features of myasthenia. The relatives were not willing to take any risk. They were willing for IV immunoglobulin. So nivolumab was stopped. Tablet pyridostigmine was started. Prednisolone was started as tablet, 50 milligram OD. And immune-related myasthenia and its prognosis was explained in detail to the family. Family was willing for IV immunoglobulin. So IV immunoglobulin was given for 5 days. He had a very good response to IV immunoglobulin. He improved over 2 to 3 weeks. He was started on mycophenolate mofetil and steroids were tapered over the next few months. A repeat AChR antibody came negative after 6 months. He was stopped. Mycophenolate was stopped and he is asymptomatic at present. So this case I'm mainly presenting for the therapeutic challenge, whether to start IV immunoglobulin or not, because the patient did not have anything other than ocular myasthenia. So I was like, who would start even IV methylprednisolone for a case of ocular myasthenia? We would only start oral steroids. So we didn't want to take any chances. The family was not willing to take any risk. So I treated ocular myasthenia with IV immunoglobulin.
That's perfectly okay. Is he still on nivolumab?
No, sir. He's off nivolumab.
That's fine. So unlikely that the myasthenia will progress, isn't it?
Yes, sir. Yes, sir. All medications have been stopped now.
Okay, good.
Because this patient I had seen earlier, the next patient, I was very sensitized. So when that patient came, I thought it could still be nivolumab, and I did the literature search, and then I could correlate the findings. Otherwise, I also could have missed the first case.
Excellent. Very nice.
Can I add, Dr.
There are some chat box, there are some comments.
Sir, I have one more case too.
Oh, sorry. Go ahead.
So neurological syndromes associated with immune checkpoint inhibitors, they can be central or peripheral. Central can be encephalitis, meningitis, CNS demyelinating diseases, myelitis or vasculitis. Peripheral nervous system, it can be myositis, myasthenia, demyelinating polyradiculoneuropathy, cranial neuropathies, and demyelinating polyneuropathies. The important point to note is many of the neuropathies are steroid responsive. It is only the myasthenia which requires immunoglobulin. GBS-like presentations do respond to steroids. So the third case, this has nothing to do with ICI. So he is a 47-year-old male. He presented with blurring of vision left eye for the past 3 days, noticed on waking up. Difficulty perceiving colors in the left eye. He had no pain or he did not have any pain on ocular movements. There was no history of headache, vomiting, double vision, jaw claudication, fever or weight loss. He's a type 2 diabetic with uncontrolled sugars. He did not have any joint pain or connective tissue disease. No history of hypertension, no history of smoking. Blood pressure was normal. Visual acuity on the right eye was normal. Left eye was 6/60. Left eye showed RAPD. Color vision was impaired in the left eye. Fundus showed bilateral disc edema with non-proliferative diabetic retinopathy. There were telangiectasias seen over the disc. There was no tenderness over the temporal artery. Temporal artery pulsations were normal. No other focal neurological deficit. This is a fundus photograph showing bilateral disc edema. It was more on the left. The disc edema was mildly pale. It was a pallid edema. And there were few telangiectasias more prominently seen on the right more than the left. The visual field on the right showed a little bit of patchy defect. Not sure whether the patient reported false positive. Left eye showed monocular visual defect. So going into the discussion, it's a painless, acute, monocular visual blurring, more in favor of AAON. Pallid edema and telangiectasias on the disc suggest ischemic pathology. Presence of diabetes favors NAAON. So what is the cause of disc edema in the asymptomatic eye?
And asymptomatic eye visual acuity?
Normal, sir. 6/6. So went on to investigate. Blood sugars were high. HbA1c was 11. Lipids showed hyperlipidemia. CBC ESR was normal. CRP was normal. Renal functions normal. Thyroid functions normal. ACE levels normal. ANA negative. Sorry. Did MRI brain with contrast, which was normal. Because of bilateral disc edema, did a CSF pressure was normal. CSF analysis was normal. So this is the OCT. In the OCT, we can see that there is bilateral disc edema more on the left than the right. And this is the FFA. In the FFA, there was delayed filling and delayed leakage on both sides. This was the FFA report. That was more in favor of NAAON. VEP was normal on the right, left was not obtained. NMO antibody was negative. This case was somewhere in 2014 or 13. MOG was not routinely done during those days. So what is the diagnosis? What is the cause for disc edema in the right eye? Left eye, it looks like a NAAON. But what is the cause for disc edema in the right eye?
Diabetic papillopathy, right side.
Correct. So diagnosis is diabetic papillopathy right plus NAAON in the left eye. Treatment was diabetic control, gave a short course of IV steroids followed by oral steroids for 2 weeks, which is very controversial. Antiplatelets and statins were given. So what is diabetic papillopathy? It is unilateral or bilateral optic disc edema with variable visual loss seen in diabetics. It can occur in type 1 or type 2 diabetic, irrespective of metabolic control or severity of diabetic retinopathy. So some authors believe that diabetic papillopathy is nothing but a mild form of NAAON. Some people believe that it is a different entity. So we can call them as splitters and lumpers. Argument for lumpers. Diabetic papillopathy is considered a mild form of NAAON because both are basically due to ischemia of the optic nerve head. And diabetes is a risk factor for both. And small optic cup is a risk factor for both. And there have been many patients with AAON who have asymptomatic disc edema in the fellow eye as in our patient. They can be present either at in the same time or during follow-up. The normal eye can develop asymptomatic disc edema. And there is a terminology called incipient NAAON. Suppose a non-diabetic person develops a similar problem, NAAON in one eye and mild disc edema asymptomatic on the other eye. There we cannot use the term diabetic papillopathy. In such patients, we can use the term incipient NAAON. These cases may rarely progress to AAON. So arguments for splitters are disc edema persists longer in diabetic papillopathy than in AAON. Disc edema in AAON resolves by 3 months, whereas in papillopathy it resolves by 10 months. And papillopathy is more frequently bilateral than NaON, and they have been described more commonly in younger age groups. Diagnostic criteria for diabetic papillopathy: confirmed diabetes, optic disc edema, absence of optic disc dysfunction, normal intracranial pressure, lack of nerve inflammation, infection, or infiltration. So it's mainly a diagnosis of exclusion. Clinical features are usually they're present with non-specific visual complaints like mild blurring or distortion of vision. It can be an incidental finding. Visual acuity in diabetic papillopathy can vary based upon the extent of optic nerve swelling and presence of peripapillary subretinal fluid or macular edema. And cases with severe vision loss are most likely to be AAOL. Fundus shows usually optic disc swelling. Surface telangiectasia are very prominent in diabetic papillopathy. The vessels on optic disc are radially distributed in diabetic papillopathy as against random pattern of distribution in neovascularization. Disc edema can be, usually it is bilateral. Macular edema can be a comorbid finding. So treatment of diabetic papillopathy, disc edema can resolve in few months without any treatment, and there need not be any visual impairment. So no treatment is known to prevent subsequent vision loss from NaON or diabetic retinopathy. Some clinicians would treat with steroids based on anecdotal evidence. Periocular intravitreal steroids have been used in the past. Intravitreal anti-VEGF have been used in diabetic papillopathy. Coming to NaON treatment, we should avoid hypotension, particularly nocturnal hypotension. This should be avoided by giving nocturnal antihypertensives. Discontinuation of drugs like phosphodiesterase 5 inhibitors like sildenafil, amiodarone, interferon alpha. Secondary prevention is mainly by controlling the risk factors and probably adding aspirin. Optic nerve decompression has been shown to be not useful and may be harmful to the patient. There is no randomized control trial to support the steroid use. It is very controversial. But at the end of the day, there is no proven effective for AAON. We just cannot say the patients that there is no treatment and you have to live with a blind eye. Steroids have been used in various studies and have been shown to reduce disc edema. The Indian ophthalmologist Sohan S. Haira has investigated systematically the role of steroids. He has done a patient choice study. He has investigated with about 300 patients, and he has shown that there's a higher probability of improvement in both visual acuity and visual field, but it was not a randomized control study. So the decision to use steroids should be made after risk-benefit analysis and after explaining the patient that we are not sure about the outcome. And this may be used when the vision is really low, less than 20/70, or if the patient is monoocular. Sir, I've finished my presentation.
Sir, VN sir.
VN sir. Sir, any comment, sir? Chitram, sir. Satish.
I congratulate Dr. Priya for presenting 3 interesting cases of neuro-ophthalmology.
Thank you.
So she presented different kinds of visual loss, drug-induced and diabetic-induced. Thank you, doctor.
Thank you, sir.
Sir, in the first case, there are some questions. Can edema with acute denervation?
Sir, what is the question, sir?
It's not if it is Tangraj
Can
Jayamar. Can
Yes.
edema happen with acute denervation?
What?
Can, the next question by Tirur Chelvan, sir. Were done or not?
So first question, sir. What is the first question?
Scrutiny and edema, acute deterioration. Edema can edema with acute denervation.
Probably it is a entrapment like neuropathy. I think the muscle edema which produce entrapment of brachial plexus, that may be the possibilities, which results in axonopathy.
Okay. Then anti-cancer antibody was not in this.
Audio not clear.
AN is negative, sir. AN negative only, sir.
Then for Dr. the question,
Actually,
sleep yes.
Actually,
Dr. Priya. Sir. Bag.
Yes, sir. Sleep apnea is a risk factor for NAION, sir. It's commonly missed. I did not look for in this particular patient, sir. It should have been looked.
Sir.
Audio, I think not good.
Ama.
Madam, I just want to ask one question, madam, from I am Dr. Mehandan. I used to attend an oncology hospital very regularly, but as you have pointed out, several cases of melanomas have started living like this.
Yes.
And after the advent of this immune checkpoint inhibitor, a lot of MABs have come. All these MABs, in the interest of our enthusiasm of treating this patient, I used to feel that we forget the primary pathology. After all, you showed in the second case in the melanoma, I had a case of gastrointestinal melanoma with typical anti-renal manifestation. They even suspected I was referred as a case of motor neuron disease. And patient, of course, we gave steroids, we gave IVIG and all, but patient did not improve. But I generally told them melanoma has such prognosis is bad. So that is how, though the patient does not improve, we were able to satisfy ourselves. What is your opinion on that, madam?
About the paraneoplastic manifestation, sir?
Yes, madam. Paraneoplastic in the sense that the patient had melanoma operated. Even before that, he started having anti-onset manifestation. And of course, there was no much fasciculation, but he had typical neurogenic pattern, bibrachial diplegia, and he had fibrillating tongue, or the wasted fibrillating tongue, and he had dysphagia also. And he had typical feature of ALS, but reflexes were depressed. And he is a chronic diabetic also. Not very much. And then he was on monoclonal antibody. He was living even after surgery. And of course, MABs and all, he was living for a few years. But even then, I said that prognosis is not very good. Can we call it as paraneoplasm? Because it is along with the, of course, it was not before the malignancy as it was along with that. But it is a second case of melanoma which I had like that.
Interesting case.
Melanoma as such, prognosis not that good.
Okay.
So your patient with melanoma novelum.
My patient with melanoma had
he improved very well. He has improved very well. I was surprised with that.
No, so
which
my patient is probably a drug-induced problem, sir. So probably it was iatrogenic. It was not because of melanoma per se. It was probably because of nivolumab. So that's why he has improved. And your patients are probably because of melanoma per se. The antibodies are probably paraneoplastic. So
what
generally
happened to
paraneoplastic syndromes don't do that well. Normally paraneoplastic syndromes.
that's what we have seen. Most of the time they don't improve very much in spite of the costly treatment.
Yes, sir.
And then they all know very well that melanoma as such prognosis not that good when compared with other malignancies. When the report comes as melanoma, we are always perplexed. We are always worried. So this patient, when he was so good after that. So I thought that what happened to the melanoma?
Melanoma is still on chemotherapy, sir. They have started him on some other form of chemotherapy because immunotherapy didn't work for him. They have switched over to some other form of chemotherapy, sir. But he's doing well. Thanks to the...
That is what is surprising. Yeah. Probably the drug has acted well. Yeah. Well, thank you very much. Thank you.
Thank you.
Sir, thank you very much, sir. If there are no other questions, we will close the meeting. I thank Professor Tangaraj and Jaykumar for the rare presentation. That to a asymmetrical upper limb weakness, the man in barrel syndrome. They have postulated HNPP with myoedema due to rhabdomyolysis. That's a rare presentation. Then next, neurophthal cases by Dr. Priya. All are interesting and rare presentation. The first case, the first two cases were due to drug related. The one is without affecting color vision, there is optic nerve involvement due to the checkpoint inhibitor. The second case is again due to neuromuscular involvement due to checkpoint inhibitors. Of course, the third case is due to diabetes papillary, like that. I thank both the presenters for their very interesting presentation. I thank you one and all. I thank Professor VN sir for giving this opportunity to chair this session. We'll meet in the next forum. Then
Thank you,
thank other
Thank you, sir. Thank you, sir.
Chitrambalam sir, Meigandan sir, and other discussants for the active participation. Thank you. Thank
As
you.
usual, very high quality of cases, sir. As usual, very high quality of cases from
Yes,
Trichy.
sir. Yes, sir.
We expected this high, we as expected, it has very high quality from Trichy.
Yeah,
Very
Dr.
nice
Priya.
learning. Yes,
Yeah.
Priya, as usual, the quality
is like our MIN
as expected.
Wednesday meeting.
Yes, yes, yes.
Yes, yes.
So,
thank you, sir.
And the other Dhanalakshmi case was also very interesting.
Very interesting, unusual
Yes,
case.
yes, 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 yes.
Yes,
Thank
yes.
you, sir. Thank you.
Thank you, Chitrambalam, sir.
Sharing also was very interesting. Thank you, sir. Thank you.
Thank you, sir. Thank you.